Thank you very much, Brooke, and uh, good afternoon, everyone. I just want to say a very quick introduction before I introduce our presenters. I think the main point I really wish to make right now is that there is a very exciting and helpful community of healthcare organizations, hospitals, and other organizations that use the same EPIC system. And I just want to emphasize how important that community is for obviously for learning, for standing on on shoulders of others, as it were. But I've seen myself, having experienced a number of EPIC implementations in the UK, that community can be extremely helpful and supportive as each new hospital organization and EPIC customer goes live in the UK. And so I think in that spirit, I'm very pleased to welcome learning from others, in this case, from colleagues that have implemented EPIC at University College London hospitals in London, and then also from the Royal Devon and Exeter Hospital Trust in the west of England. So without any further ado, I'd like to very much welcome our colleagues, Steve Cohen and Paula Anderson from UCLH. Can I invite Steve and Paula to take the floor and share with us, please?
Hi, David, and hello, everyone. I'm just going to pad while Paula shares the screen because I can't be trusted in such a big event to do that. And just while she does it, to David's point, well, I'll tell you the story shortly, but as we embarked on this program, only one UK trust had done it before, and that was Cambridge. And it was David and a lovely chap called Afzal Chowdhury who we grew to know incredibly well, and he guided us through what was an incredibly challenging but rewarding process. And Paula and I have tried to do the same to everyone else in the UK who's undergoing this journey. And just to say also that our American colleagues were fabulous. We spent many hours on the phone with other CCIOs across the US as they guided us through this. So I know mainly you guys must have a ton of questions and want to pick our brains. So Paula and I will do a fairly short slide deck just showing you a bit about UCLH and the program there. And then we've got the questions that Brooke sent through, and we can talk around those or just ask if anyone wants to submit questions through the Q&A. And I think David will keep an eye on that for us. I've also got it open on my screen. So just quick intro then. I'm Steve. I'm a consultant in anaesthesia at UCLH and the Chief Medical Information Officer. And back in 2014, I met Paula, who was an informatics expert, I guess she would describe herself as at that point. And then she led one of the EPIC teams through implementation and then became the Chief Nursing Information Officer and is hugely knowledgeable about all things digital in the hospital. Roughly speaking, UCLH is set in north central London, if you can imagine, and as London kind of matured through from its small separate hospitals, gradually they merged together and became bigger hospitals, and now they're kind of grouped together in big trusts. So UCLH is kind of spanning maybe 2 miles across north central London with 5 major campuses, all doing slightly different things, with more and more services now kind of focused around the Euston Road end as we continue opening buildings to consolidate the estate. But roughly speaking, it turns over around £1 billion a year, sees over 1 million outpatients, and has upwards, well, depending on configuration, somewhere between 800 to 1,000 inpatient beds. As I said, the campus is quite broad. We have specialist hospitals such as Queen Square, the National Hospital for Neurology and Neurosurgery, slightly further east. And then we have our main campus that does most of our kind of district general hospital work, and then our tertiary and quaternary specialist hospital work. We took every site live at the same time with Epic overnight in what we don't call the Big Bang implementation, do we, David? We call an all-in-one overnight implementation with lots of success criteria. Paula, do you want to do the next slide?
Okay.
This is roughly the timeline of our story. So as I say, Paula and I met in 2014, just as David joined the trust, and we began creating the overview business case and began the procurement journey, and then formally launched the program back in 2017 once the contract was signed in Epic. So you can see how long it took us to get to that stage. It was a complicated process, and there were lots of competing thoughts and emotions as to which way we should go. But we finally united behind our program to deliver Epic, and we launched it. It then took around 16 months to configure and implement the product, and you can see the various bits of the journey kind of laid out in that infographic. And we used, you know, the timeline was incredibly useful for helping engage, as you say, the hearts and minds of people. It became increasingly obvious to people that this was the biggest thing that we were going to do to the hospital, and you needed to be involved in it. So we used this heavily as a kind of communication tool. Paula, do you want to do the next one? Oh, you've done it already. You're so far ahead. I'm looking at my deck just so I can read it. In terms of the scope of the implementation, we took a implement as much as possible approach. So Epic replaced as many systems as possible. Even if there was a good best of breed system installed, we would remove it if Epic had the offering. So a good example of that was critical care. Our critical care was on its second version of an electronic system. It was incredibly happy with it and was doing great things from a data perspective with the health informatics collaborative programs running. But we chose to remove it because we knew that having a complete record from the front door to discharge through to outpatient work was going to be our transformative catalyst, I guess is the best way to describe it. So we put everything in that Epic had, with one major notable exception, which was the Beaker product, which is for the labs. And the reason for that was UCLH has a joint venture across us, the Royal Free, and some private hospitals around Harley Street, and our labs are outsourced, and we had no power over the lab system. So we retained the outsourced lab model and interfaced and integrated Epic with that, which was complex, but now works well. And also our dentist at the Eastman Dental Hospital felt that the Wisdom offering, when we looked at it, was not quite up to what they required. So we held off on Wisdom, and now we are currently implementing it as it's undergone more development from Epic. So basic principle, put as much of Epic in as possible. Paula, do you want to do the next one? And I'm handing over to you, I think.
Thanks, Steve. So the way Steve and I have structured these slides are hopefully just to give some thoughts around particular areas of the Epic implementation. So we're hoping to have more of a discussion rather than us just talking at you, but we thought these might just be some prompts. So certainly around the beginning of the implementation process, for us, it was really interesting trying to get the right people at the table, who were the decision makers, who were going to be our subject matter experts, how were we going to release them for the time that they would be needed. And we needed people to be released who could make decisions. So we also felt that we didn't necessarily bring enough of our frontline staff into the decision-making process. So we had a lot of, let's say, matrons and senior clinicians and senior managers, but we didn't really bring our band 5s and our healthcare assistants in. And they're the main users of the system. So actually from an adoption and bringing people on a journey, we should have brought our frontline users in to the decision-making process and the journey around Epic and the implementation a lot earlier than we did. One of the main challenges we had in getting people to our meetings was we weren't giving them enough time. So ideally, we were supposed to give 6 weeks notice for clinicians to attend any of the meetings. We were lucky if we were getting the invites out within 3 weeks to go. So really, really important to be prepared and understand who is going to be invited. And then the other area that we really looked at was how were we going to sign off? What was that final sign off that would stop anybody going, oh, but can we just change? Can we just change? Because there was a lot of that as we moved through the implementation journey. As the organisation and our build teams learned more about the system, we would reflect back and go, oh, we could just change X, Y, and Z. But changing X, Y, and Z would maybe add another 3 days of work. And when you've got a strict deadline to meet for your go live date, you're very tightly constrained in terms of what you can do and build. The other thing, and I think this relates to one of the questions that was in the chat, certainly from my perspective, and I'd be interested to hear what Steve says, we should have brought our clinician builders in earlier. So we didn't set our Epic expert community up until post go live. And it's a really well functioning community at the moment. And we are still working through how our expert builders actually work with the EHR build team. We've got 2 people that are expert builders who were reasonably embedded with the implementation team as we were building. So our uptime and anaesthesia team had a really engaged SME who's now one of our clinician builders. And that model where she was really embedded in the team during implementation has paid off dividends for post go live, and her capability and ability to support the builder program. And also the other thing around people is about understanding super users and their roles post go live. So we had about 1,700 named super users. We still have 1,000 on our mailing list. But we no longer have an active plan on how we manage and support them. So during the implementation, they got additional training, they had question and answer sessions, and we had a whole support process that doesn't exist anymore. And if we were doing this again, we would have had a better plan around how we maintain and utilise the super users moving forward. Steve, I don't know if you've got anything to add.
Yeah. David, I think we might come back to the questions once Chris and Pippa have presented. Is that I'm just seeing your kind of guide come through, just specifically on the clinician builder stuff, Paula. Yeah, I agree with you, and that is one of our top lessons. You know, certainly from my perspective, is get people trained up in that early. And I suspect in the questions we'll drill slightly deeper on total cost of ownership of Epic and what you can do to mitigate that whilst balancing your kind of digital aspirations, because UCLH took the perspective that the go live was the end of the beginning, or whatever, however you want to describe it. So we went with a safe, minimal product as much as possible when considering what you might do for all your specialties, trying to get a specific build for your N=1 clinician in an outpatient room, for example, just not achievable when you don't really know and you're not live. Yeah, Paula, I'll stop and we'll drill back in once Chris and Pippa have gone.
Great, thank you. So the other area that we would focus on again is around end user technology. There was a bit of a split in terms of how the end user technology was allocated, or at least designed within the programme. So from an inpatient's perspective, the CNIO and the matrons took the lead in terms of understanding what the kit requirements were out on the ward, to the degree of even looking in the treatment rooms to see whether we could put a screen on the treatment rooms, or whether there were cupboards all over the walls and we couldn't get a screen up. It's about also understanding, are your devices able to go into rooms? Are your rooms big enough? So we have treatment rooms where we can't get our workstations on wheels in because the workstations and wheels are too big. So really understand what devices you need. And I think the other lesson for us is understand what you need on your devices. So if I think about our ITU scenario, we have a workstation at each bed, but they're locked down. So the only access you have is to Epic. So if the nurse is at the bedside doing all the Epic documentation, it works really well. But if there's a challenge and they need to raise what we call a DATEX, I don't know if you use that in Northern Ireland, but it's our system for logging incidents and issues and falls and pressure ulcers. The nurse can't access it from the bedside. So they do all their documentation on Epic and then have to find somebody else to look after the patient while they go to a workstation elsewhere to actually log the incidents. So we have now unlocked the machines in ITU to allow DATEX access at the bedside, but it wasn't something we did for at least 6 months post go live. And I think one of the other interesting things that we've discovered is we had a lot of iPhones for Rover devices for barcode medication administration, for healthcare assistants to enter vital signs in. And we had iPads that we were expecting medical staff and other staff to use the Heiko and Canto apps on. But the apps don't give you the full capability of Epic. So the doctors and the medical staff still want the workstations on wheels to go round and do their rounds so they can enter data, which means there's a little bit of conflict in areas in terms of the nurse wanting the WOW, the workstation on wheels to do barcode medication administration. The medics wanted to do their ward rounds, the dietitians want to do their bits and pieces. So you really need to set expectations around device usage. And I think the last thing I'll say on technology is having end user technology for the use of a clinical system is different to the technology and the software that you need for being a digital organisation. So if you want to be able to do your whole day in a digital organisation, you need to provide technology or kit that allows people to use MS Teams or Zoom, as well as your clinical system that allows them to get to their email, that is mobile if they're needing to move between areas. And I think we're going through at the moment a bit of an end user tech review and in terms of looking at what personas do we have and what do they actually need in terms of software access and devices. The other area that, moving on to data, is when you set up Epic, certainly around staff records, you need to populate Epic with a lot of user information. We chose to use our national ESR staff record, where the data was so dirty that we struggled. I can't think of a better word, actually. It was so dirty. We use the data to assign roles to people. So in our ESR, you might have a member of staff who was down as a doctor, but actually when they phoned the help desk, they were a nurse consultant or they were a dietitian, and their role in Epic really didn't match what their role on the staff system was. And we still have trouble with that today. It's not something that we've managed to fix, but it is about fixing the issues at the source, and it's quite difficult to fix data quality at a national system. And I think that goes for all data that you're bringing into Epic, but particularly staff information has been a bit of a challenge. Let's move down to the next one. And I've come on to that one slightly, but so our next area of what we would do things differently is obviously ESR, which I've just talked about, and creating user accounts. We created an awful lot of user templates in Epic. We should have rationalized them. We didn't need 300 different user profiles. We probably could have got away with 100. Also thinking about streamlining recruitment and onboarding processes. UCLH took a decision that no training, no access. So you might have a member of staff start, and this is certainly post go live, a member of staff start on the 3rd Monday of the month, but the next induction and training isn't until the following month. So there's 2-3 weeks while a member of staff can't use Epic. So therefore their documentation and ability to care for the patient is limited. Bringing in Epic also brought to the head a number of areas of inappropriate practice. So get ready to tackle that one. We found healthcare assistants undertaking tasks that were within their scope. And then we had to not only work with the line managers to understand why, but also maybe even look at more HR issues around those areas. And then bank and agency staff access, really work out how you're going to do that. Again, if you have a no access, no training policy and you've got somebody coming in with 2 hours notice, they need to be able to use Epic. Training, you can never train enough super users. As I said, I think we had about 1,700 on the books for Go Live, which is now dropped down to about 1,000. One of the other areas that we had a bit of a learning about was our e-learning system. It wasn't necessarily the best system to use for booking all the training. Comms, you can't engage enough with your frontline staff, or in fact with anybody. Talk about it, be open and honest. We were really lucky in that our CEO of the time, Marcel, had just come from doing a implementation in Amsterdam, and he was quite, I want to say, quite brutal with everybody in terms of the clinical staff. He was, you know, you will not like this. The first 2 months of implementation after Go Live will be difficult. You'll be frustrated. It will take you longer to document, but it's worth it. Within 2 months, you'll wonder what you ever did without Epic. And it's true, it will be difficult, it will be frustrating, but within a couple of months, you will wonder how you ever managed without the system. But it's actually managing those human behaviours and the behavioural change. I think I heard somebody earlier say, this isn't an IT programme. It isn't, it's a cultural behavioural change programme. You can give people as many devices or pieces of kit as you want, but you need that behavioural change to get them to use it. And I think the other thing that we would look at differently is, how do we communicate with the staff? Email doesn't work. What other ways can you get that information out to staff? And then I think the last thing I just want to briefly cover is, when you're looking at the build of the system, think about the multi-professional team. Don't build in a single professional role. As a nurse, I enter information that other people utilise. If you only think about how I enter the information, the way that somebody else views that information, it's not going to work. So you need to think about that complete picture.
Paula,
yep.
I'm sorry. I'm just mindful of the time, so I wonder if I could just very politely ask you to kind of maybe summarize quickly, so we can let our RD&E colleagues present, and then, you know, we can cover other points during Q&A.
Yeah, so I think I'll just go straight down to Go Live. So during Go Live, make sure you've got appropriate senior leadership cover. Double check all your safety huddles and your dashboards. When you're utilising the Epic dashboards around Go Live, just really make sure they're working. And I think there's two components to Go Live. One is the operational side, and the other is your actual EHR team. Your build team need feedback. They will be quite concerned during the whole of the build process that their build might be wrong and it will cause harm. They need reassurance, actually, that what they've done is the right thing. And if something does go wrong, there are processes around to support and not hold blame. So at that point, I will stop, and thank you.
Thank you so much, Paula. Really great points for us to consider.